Hi everyone, Paul, Randy, Talia, and I will be presenting the disorders of the thyroid gland. And before we begin, this is just an overview of what we're going to be discussing. So first, we're going to be going over over hyperthyroidism. Then we're going to be talking about hypothyroidism, and then we're going to go over our case study and then our overview.
Awesome. Thank you for that, Anna. So, what is the thyroid system? The thyroid system is basically deals with the thyroid gland, the anterior pituitary gland, as well as the hypothalamus. They all kind of work together. The thyroid gland produces three major hormones, which are thyroxine, triiodine, thyronin, and calcitonin. And then anterior pituitary gland is going to produce and release the hormone TSH, which is thyroid stimulating hormone, which stimulates the thyroid gland to produce the three major hormones. And then the hypothalamus produces the thyrotropin releasing hormone, which is TRH. And that is released dependent on if there's low levels of thyroid hormone or high levels, and then it's going to regulate the the amount that needs to be in the body. And then C cells are the ones that produce the calcitonin, which regulates the calcium levels within the body. All right, next slide. All right, so hyperthyroidism. So basically, hyperthyroidism is when the thyroid glands are going to overdrive, where they are overproducing as well as secreting thyroid hormones. The most common disease is going to be Graves' disease, and other causes could also be thyroiditis as well as excess iodine intake, pituitary tumors, and goiter. Um, and the most of this is going to be characterized by an enlarged thyroid gland. And briefly for Graves' disease is an autoimmune disease, which antibodies are produced and they will attach to the receptors that the TSH will attach to, and it will cause overstimulation of the thyroid gland. Slide. So I included three or four nursing concepts: gas exchange, nutrition, activity intolerance, as well as infection. I included fatigue due to hyper, or the patients will be going through hypermetabolic rate, and they're going to have an increased demand of energy, which can lead to exhaustion. And then you can also have risk for imbalanced nutrition, less than the body requirements. This is due to hypothyroidism causing patients to have a hyperactive metabolic rate, which can cause the body to burn more energy than they normally would. Uh, and then you can also have risk for decreased cardiac output, where because of the hyper metabolic state that the patient's in, the body is going to require a higher demand of oxygen as well as nutrients, and it can also cause an increased strain on the heart. And risk for impaired tissue integrity is due to issues with the eyes. Um, Hypothyroidism can cause the eyelids to have impaired closure as well as protrusion of the eyeball, which can lead to increased risk of eye infection as well as compromised visual function.
So what are some risk factors that we may need to look out for? These include iodinated contrast media exposure. Women are more commonly affected than men. Pregnancy, family history, smoking, infection, and stressful life events. I also included the reasoning for that as well. Next.
Now we're going to get into these signs and symptoms of hyperthyroidism. These are mainly due to increased metabolism and tissue sensitivity to the SNS stimulation. In the thyroid gland, we might see goiter and bruit. We might also see ophthalmopathy, which is abnormal eye appearance and function. Exophthalmos, which is bilateral protrusion of the eyeballs due to edema in the orbital tissue and ocular muscles. Retracted and elevated eyelids may cause dry and irritated eyes. Corneal ulcers, vision loss, diplopia, which is double vision. And then we might also see weight loss, nervousness, acropathy, which is clubbing of the fingers. In older patients, we might see confusion and agitation. And patients may also experience heat intolerance, diarrhea, increased sweating, and racing heart rate.
So for laboratory and diagnostic studies, we may see a decreased TSH and LDL level. as well as a increased T4 and BMR level. Another test that we can do is the RAIU test, which is the radioactive iodine uptake test. This distinguishes Graves' disease from other forms. We can also do an ECG because patients with hyperthyroidism may develop atrial arrhythmias such as sinus tachycardia, and I did include the normal ranges for each of the laboratory values.
A major complication of hyperthyroidism is acute thyrotoxicosis. This is also known as thyrotoxic crisis or a thyroid storm. It is due to the excess thyroid hormone being released into the circulation, which may result from hyperthyroid patients experiencing stressors such as infection and trauma. Signs and symptoms of the thyroid storm include tachycardia, heart failure, shock, hyperthermia, agitation, delirium, seizures, abdominal pain, vomiting, diarrhea, and eventually coma. Other complications include irregular heartbeat and osteoporosis.
Okay, so for nursing interventions, we will break it down into two categories, acute thyrotoxicosis and thyroidectomy. First, acute thyrotoxicosis. As always, we should assess our patient, and you can review the assessment points on this slide. Our next intervention is administering medication. For acute thyrotoxicosis, we will administer drugs that block the thyroid production and the sympathetic nervous system. This includes beta-adrenergic agents and anti-thyroid agents. Additionally, we may administer acetaminophen to reduce the patient's fever. When monitoring the patient, we should monitor the patient's airway, breathing, and circulation, and vitals every 30 minutes. We should also administer an IV to replace any lost fluids or electrolytes, apply ice packs and cooling blankets to reduce fever. And when exophthalmos is present, we can elevate the head of the bed to relieve pressure and apply artificial tears to relieve dryness. Lastly, it is important to create a restful environment. We should promote a calm, quiet room, keep the room cool and use light linens. And when possible, place the patient in a room away from busy, high traffic areas and reduce visitors. Next slide, please. Now on to patients undergoing a thyroidectomy. Interventions for thyroidectomy include medication administration, patient education, and monitoring for complications. Medications are similar to patients with acute thyrotoxicosis with the addition of iodine. Iodine helps achieve a euthyroid state prior to surgery and helps reduce possible hemorrhage. Education points include teaching the patient how to support their head when turning to prevent added stress and pressure on the suture line. And as far as monitoring, we should monitor vitals every 15 minutes post-surgery until the patient is stable, and then every 30 minutes after that for the next 24 hours, as well as monitor for potential complications such as hemorrhage, tracheal compression, and signs of tetany or hypocalcemia. And other interventions include assisting with deep breathing and coughing, administering IV calcium for hypocalcemic patients, and placing the patient in a semi-Fowler's position. For collaborative care for hyperthyroid patients, diagnostic assessments such as ophthalmic examinations, ECG, and laboratory testing may be needed. Drug therapy, as we've discussed previously, and other therapies such as radiation therapy, surgical therapy, and nutrition therapy.
All right, so now we're going to move on to hypothyroidism. So hypothyroidism is basically the complete opposite of hyperthyroidism, where now the thyroid gland is having a deficiency in producing as well as secreting thyroid hormones. And the main issue also is going to be that it slows down the patient's metabolic rate, unlike hyperthyroidism. And normally this is going to be seen by increased TSH as well as decreased T4 levels. So there's going to be primary hypothyroidism, which is affecting the thyroid gland itself, where there's going to be either destruction of the thyroid tissue or there's going to be a defect in hormone synthesis. Secondary hypothyroidism is caused by the pituitary gland having issues, either by pituitary diseases or just being impaired and it's going to be shown through decreased TSH or hypothalamic dysfunction with the TRH secretions. And then the most common is going to be iron deficiency. And then other causes could be thyroiditis or sudden stopping of thyroid hormone therapy and usually develop. And so nursing concepts, there's nutrition, there's patient education, as well as sleep. And for patient education, it's going to be deficient knowledge where patients are going to require a lifelong medication management as well as a change in lifestyle. So educating the patient is one of the priorities towards managing the disease, as well as having the patient perform self-care to treat the symptoms. And then you also have fatigue, where the patient with hyperthyroidism will have or be in a slower metabolic status. So they are going to have less energy and will require more rest as well as adequate sleep. And then you're going to have imbalanced nutrition more than the body requirements in the patients due to having a lower metabolic rate. They're going to have to watch how much they're consuming so that they don't gain too much weight, because there's risk of obesity as well as other issues that can arise from consuming too much food.
Risk factors for hypothyroidism include iodine deficiency. So we don't want to have too little or too much iodine. History of autoimmune disease, thyroidectomy, radioactive iodine therapy, medications such as amiodarone, smoking, and women. Next.
Signs and symptoms of hypothyroidism are due to slowing of the body processes. So patients may experience being lethargic and tired. They may have mental changes such as impaired memory, slowed speech, decreased initiative, and somnolence. Other symptoms include depression, weight gain, cold intolerance, constipation, decreased sweating, and slow heart rate. There may also have cardiovascular problems, which are due to a decrease in cardiac contractibility and output. So they may experience low exercise tolerance, shortness of breath on exertion, atherosclerosis, and anemia. Other signs include myxedema, which is due to the hydrophilic mucopolysaccharide accumulation in the dermis, which causes facial and periorbital edema.
Laboratory and diagnostic studies include an increased TSH level, total cholesterol level, triglyceride level, and an increased creatine kinase level. T4 and the basal metabolic rate would be decreased. And then we would also have a positive thyroid peroxidase antibody in autoimmune hypothyroidism. Next.
A major complication of hypothyroidism is myxedema coma. This is when the body's compensatory responses become overwhelmed due to stressors on the patients with hypothyroidism. This may be from infection, drugs, or other types of trauma. The signs and symptoms include subnormal temperature, hypotension, hypoventilation, hyponatremia, and hypoglycemia, which eventually causes death. Other complications include peripheral neuropathy and infertility.
Okay, so for the hypothyroid patient, we of course want to begin with a focused assessment, and you can review the assessment points on this slide. However, for patients experiencing a myxedema coma, it is vital to perform a cardiac assessment, assess energy levels and mental alertness, neurologic status, and continually monitor TSH levels. Interventions include administering IV thyroid treatment. It's important to administer medication intravenously as the patient may be experiencing gastric hypomobility. We should monitor their core temperature for hypothermia, as well as clean and moisturize the patient's skin to prevent breakdown. These patients are prone to weight gain, so we should also monitor intake and output, body weight, and assess for any signs of edema. And next, we'll move on to patient education. As Paul mentioned, the patient should be taught that this will require lifelong treatment. They should not stop their medication abruptly or double up on doses. They should contact their healthcare provider if any abnormal symptoms develop, and they should be taught that ambulation and exercise may help with constipation. Next slide, please. For collaborative care for the hypothyroid patient, it includes pharmacologic therapy, diagnostic testing, and nutritional therapy, and you can review more details on this slide. And we've also discussed these therapies on previous slides.
So I will now be introducing our case study. So we have a 16-year-old female that arrived at the hospital with a slowly enlarging mass on her front neck. The mass was painless and had begun growing over a 3-year period. The egg-shaped mass was painless, symmetrical, and did not cause any swallowing difficulties or voice changes. The patient also complained of a lack of concentration and becoming easily fatigued, although she is able to complete her normal life activities. There were no complaints or evidence of any weight loss, fever, cough, shortness of breath, or nausea and vomiting. The patient has no relevant medical history related to her current condition, with no prior hospital admissions as well. She had menarche at age 14 with regular menstruation every month thereafter. Her nutrition, growth, and development are within normal limits, and her immunizations are up to date. She does report a family history of an aunt with a struma treated by surgical management. So her assessment is as follows. She is a female, age 16. She weighs 44 kilograms and is 158 centimeters tall. Her BMI is 17.8, so just below the average. She, as mentioned, she does not have a prior medical history, and her vitals are, her blood pressure is 120 over 80. Heart rate is 98, respiratory rate is 20, and her temperature is 36.9, which is all normal for the most part. As for her assessment, they did not notice any except thalamus. The thyroid gland was palpable, non-tender, enlarged, mobile, warm, and moist. She had no cardiovascular, pulmonary, or abdominal abnormalities. Her TSH, her T3 level were under the normal range, and her T4 and TGAB were a little increased. Her thyroid peroxidase antibody came back as positive, and the electromyography came back as normal. And whenever they did the thyroid ultrasound, it came back as enlarged.
Now we're going to get on to the questions. So number 1, what is the patient's diagnosis? All right, it's going to be A, which is hyperthyroidism. She has Graves' disease. Number 2, what information supports your patient's diagnosis? Select all that apply. It's going to be A, B, C, E, and F. The labs show low levels of TSH, high levels of free T4, and low to normal levels of T3. Physical exam showed enlarged thyroid gland, and she is easily fatigued, which are all signs of hyperthyroidism. The other answers are wrong because the patient's age doesn't relate to the disease, and palpable thyroid gland is a normal finding. Number 3, what is the patient's treatment? It's going to be A, 5 milligrams of thiamazole once daily. Thiamazole is an antithyroid specifically indicated for the treatment of hyperthyroidism. The other answers are incorrect because levothyroxine is indicated for hypothyroidism. Acetaminophen is indicated for fever and will not affect the thyroid gland. And amiodarone would worsen hyperthyroidism. Number 4, top 3 nursing concept and diagnosis for the patient. Select all that apply. It's going to be A, B, and D. Activity intolerance because the patient mentioned fatigue during her exercise. Risk for altered thought process because the patient mentioned lowered concentration and attentiveness. And hormonal imbalance because the patient has hyperthyroidism. The other answer is wrong because there is no evidence to suggest that this patient has trouble with elimination currently. Number 5, what are some assessments for the nursing concept? Select all that apply. All right, it's going to be A, B, and E. Assess the patient's activity tolerance and fatigue to form proper teaching. Assess the thinking process, determine attention span and orientation to place, person, or time. Monitor physical and mental changes due to hyperthyroidism worsening. And the other answers are incorrect because the patient does not have diabetes or fluid imbalance currently.
Okay, so here are some extra case study questions. Question number 6, what are some ways the nurse can intervene to satisfy the patient's needs? And the answers we chose were encouraging and assisting with exercise involving large muscle groups, helps with any restlessness that may be experienced, provide a quiet environment, decrease stimuli, cool room, dim lights, and limit procedures and personnel. And 3, administer proper medicine for hormonal imbalance. Question 7, what teachings can the nurse do to ensure the patient's illness is maintained? And the answers we chose for that are teach the patient to take rest periods during exercise, as she mentioned, being easily fatigued during her workouts. Teach the patient ways to concentrate and relax, such as using thought-stopping techniques, since she mentioned worsening concentration and attentiveness. And teach the patient complications of hyperthyroidism and medication adherence. And question number 8, what is one relevant QSIN competency for the patient? And the answer we chose, you could have chose a few, but we chose teamwork and collaboration, communication between ultrasound, primary physician, family members, dietitian, nurse, and the patient.
So here is the outcome of the case study in case you're interested to read about it later on. And we just have an overview of our presentation for helping you to study And we have a table comparing both hyper and hypothyroidism in all the sections. And that is all. Thank you so much for listening. And if you